Hello, I am Dr. Mark Friedman, a professor of neurology at the University of Ottawa in Ottawa, Ontario, Canada, and the director of the Multiple Sclerosis Research Clinic at the Ottawa Hospital General Campus. I'd like to welcome you all to this spotlight presentation on updates in multiple sclerosis management at AAN 2010, considerations in safety, switching, and emerging therapies. Our panel will cover some of the clinical relevance of many of the key findings from the abstracts, posters, and presentations presented here in Toronto at the AAN 2010 as it is related to the treatment of MS. And I'm joined today by two of my colleagues, Ms. Amy Perrin-Ross, a certified neuroscience advanced practice nurse and neuroscience program coordinator at the Loyola University Health System in Maywood, Illinois, and Dr. Bruce Cree, an assistant professor of clinical neurology at the University of California in San Francisco. Welcome and thank you for joining us.
Thank you.
Thanks, Mark.
If the reality is control, it's like a diabetic having one glucose that's elevated. You're not going to change everything on the basis of that. What's your threshold? One new lesion, is that going to trigger it? A sensory attack? You must have some idea of what your thresholds are going to be.
Sure. Well, in my personal practice, if I have a patient who's been started on therapy, has had a reasonable time to be on treatment, and they evidence new disease activity, such as contrast enhancement on MRI, particularly if you see multiple lesions or large lesions, despite being inherent with treatment, I have a pretty low threshold for moving on in such a patient. Also clinical activity, so change in EDSS score, change in cognitive function, change in relapses and new relapses. So I think when a patient really starts to evidence that the amount of disease activity has increased, you have to start having that discussion with your patient. But the decisions are never up to us, in its entirety. All we do is provide a resource of information for our patients and to give them options.
And I think that really points, Bruce, to certainly the way things go in my practice, but it points to the importance of setting up those realistic expectations with patients from the beginning. Right. Because none of the therapies that we have, nor any of the therapies that I can see in the future, are going to totally stop this disease. Right. So people will still have symptoms, and because they're having symptoms doesn't necessarily mean that their therapy is ineffective. We have to take the whole picture in, and we look certainly at MRI as well as clinical activity and try to differentiate what's a chronic symptom in a person, what's a disabling symptom in a person, versus what are really some new evidence of relapse or inflammatory activity.
So symptoms by themselves don't necessarily indicate disease activity per se. It's so hard to sometimes get patients to understand that.
Yes.